Chairpersons, ladies and gentlemen, secondary prevention. We all do interventions. We treat patients with coronary artery disease. Important thing is prevent second event, because second event is much more harmful to the patient. So if we recap, what we do in secondary prevention is cardiac rehabilitation, lifestyle intervention, and medication. Today we are going to only focus on anti-lipid medication for prevention of secondary event. The reason being, this particular study done on 6 lakhs patients from 2019, which shows that almost 50% patient not on statin after having ASCVD or intervention. And those who are having, only 22.5% having high statin, high intensity statin, and rest are not having high intensity statin. And ASCVD, we know that we recommend high intensity statin for all of them. So this is a very surprising. In America and Australia, this study was done. So Indian may be even worse. What we want to achieve with the secondary prevention is prevent morbidity, mortality, and improve the quality of life. If we look at the India-centric anti-lipid therapy, India has a typical dyslipidemia, which is high in triglyceride, and LDL-C is normal, but it is predominantly small dense LDL, and HDL-C is low. So these are all. Why LDL-C is normal, yet it is highly atherogenic? Because of the insulin resistance, and that initiates the CATP pathway and leads to small dense LDL, which is highly atherogenic. Then second target, it's not only LDL-C target we need to look at, we also need to control non-HDL-C target, which is ApoB. ApoB is a better parameter to control because it can be directly measured. This is indirectly measured as non-HDL-C, but both have similar content, LDL, LPA, IDL, and VLDL, and chylomicrons. All entire gamut is there. So both targets are very important. Why we need to control non-HDL-C? You can see that 30 years follow-up in men and women shows that if the non-HDL-C is not controlled, then cumulative cardiovascular disease incidence goes up significantly. So what are the targets in very high-risk patient? HDL-C less than 50, lower the better, and non-HDL-C less than 80. These both targets are very important for secondary prevention. And most of these studies have shown that lower the better, and definitely it has an impact on secondary prevention. We thought high HDL is protective, but not always. If it is more than 60, it can cause several problems: infectious disease, cancer, diabetes mellitus, kidney disease, lung disease. So we have to control both. Now coming to what we have is a foundational therapy, that is statin. And statin main role is it inhibits HMG co-reductase and thereby delipidates the plaque. And when plaque is delipided, it stabilizes. From hot plaque, it becomes a stable plaque. And this can be detected by NIR and also the PET-CT, that plaque is hot or now stabilized. What happens when we give statin? It becomes a calcific plaque, that is sure, over a period of time. But statin has pleiotropic effect. It improves endothelial dysfunction. reduce inflammatory response, stabilizes atherosclerotic plaque, reduce thrombogenic response, inhibit vascular smooth muscle cell proliferation, and inhibit cardiac hypertrophy. So this has a great impact on reducing ISR post-intervention. The most important thing that I would like to highlight, if a patient is on statin and if he gets MI, he will do better than the patient who's not on statin. That is for sure. So stabilizing a plaque is very important. And then we have the legacy effect, which is demonstrated by Voskop's trial over 20 years of statin, and that seems to be very effective. So stabilizes the plaque, that is 100% universally accepted. Can statin reduce the plaque burden? Yes, reversal trial has proven that atorvastatin definitely reduces plaque burden. Does it shrink the plaque? Glogav trial has shown that it reduces the plaque, it shrinks the plaque, but it doesn't make the plaque disappear. So how does one get a maximum benefit of statin? That's the long-term statin. Minimum 2.5 years is certainly required for getting a maximum benefit of statin, but if you take lifelong, as Dr. Braunwald suggested, if you maintain your LDL cholesterol less than 70 from the age of 20 till 108 years of age, you do not develop blockages or heart attack. So what is statin doing? Why is there any mortality benefit? Yes, it reduces the MACE by 30 to 50%, and it reduces mortality in men and women. Statin is high or low, the LDL is high or low, doesn't matter. You still need to use statin for both primary and secondary prevention. So if alone statin is not able to control, we can add bempedoic acid. Clear Harmony and Clear Wisdom trials have very clearly shown that it does have both together use better control in case statin alone is not able to control the LDL-C level or non-HDL-C levels. Then if statin intolerance is there, then bempedoic acid can be used. It can be combined with ezetimibe to reduce further. So bempedoic acid, ezetimibe, atorvastatin, this triple combo is very useful, and it gives very good 63% LDL-C control and also 50% the non-HDL-C control. The intolerance to statin is 9.1%, but in clinical practice I don't see that much. I see less than that. And I have seen that those patients who have vitamin D deficiency and hypothyroid, the statin effect do cause myalgia in them more, but if you try to correct their vitamin D level and hypothyroidism, the myalgia goes up. So in statin intolerance, never stop the statin immediately. Change over to different form of statin, lower the dose, make it alternate day. This is very important. So if you continue statin, discontinue suddenly, there is a rebound effect and you may have a secondary event. And no statin means higher secondary events. Statin continued lowers the event, very clearly proven by the studies. So if the patient is allergic to rosuvastatin, atorvastatin, then pitavastatin is one which is usually tolerated well, and in combination with ezetimibe, bempedoic acid, it gives excellent result. Same way in elderly, you should never stop statin even after the age of 81, and that gives a mortality benefit and reduce the secondary events. Pregnancy also, it has no congenital abnormality effect or risk of congenital abnormality, but it does cause low birth weight of the baby, but you can give statin in a titrated dose in the pregnancy. Then coming to triglyceride, it is very important and relevant for Indian patients. Many patients have very high triglyceride because of our diet or lifestyle, and this is very important that Ecosoap paint has a tremendous effect on lowering triglyceride, and you can see the graphs separating with when you compares with the placebo, it reduces the risk hazard ratio and also reduces the events. So in conclusion, the icosapent reduces event by 48% overall. Sometimes statin alone may not be effective. Even when we try triple combo may not be effective, we can try the favorable PCSK9 drug, which has been used widely all over the world, but it does not have any mortality benefit. As such, most of the studies have not shown. But in acute MI, if the LDL-C is high, we can try that and give that. So in case, then inclisiran is wonderful drug. It's like a metabolic vaccine once, and it is very effective for 6 months. Control the LDL-C level less than 55, Orient 9, 10, 11 trial shown, but outcome mortality benefit yet to be proven, but now phase 4 trials are on, so we will come to know about it. LPA in Indians is very important risk factor for secondary prevention. 25% of Indians have very high LPA, and we don't have any effective drug to control it. Currently, we are using inclisiran PCSK9, but they control only moderately or mildly. But new drugs are expected to come soon, pelacarsen and olpasiran. Both these drugs are in phase 3 trial, and they are very highly effective. Why we need to reduce LPA? Because it's highly atherogenic, it's pro-inflammatory, pro-thrombotic, and causes a lot of calcification in coronary and even aortic valve. So this is very effective drug. Phase 3 trials are on. 75 milligram olpasiran every 3 months reduced the LPA by 97%, which is very, very effective, and pelacarsen also. So we have a patient now, we see that heterogeneous familial hyperlipidemia is very common, 1 in 200 in India. And how to control them? They have very, very big secondary event and premature coronary artery disease. Buprenorphine has been very effective. It's available, it's FDA approved, 15 milligram per kg once a month dose via intravenous infusion, and it's very effective in controlling that. This is the effect that it has shown. We have to increase. The most important thing is, particularly if you have a homozygous or heterozygous familial hyperlipidemia, gene editing therapy trial has begun in New Zealand, and one patient has been declared successfully treated. It is once done and done forever. So in conclusion, I would like to say it's very important to prevent secondary event for all our patients. Otherwise, they will have a very poor prognosis. Thank you very much.